So today we are going to study about diabetes insipidus. This is a question usually arises for 5 marks or 10 marks. Okay, so let's start. Diabetes insipidus (DI) is an uncommon disorder resulting from deficiency of vasopressin or, or antidiuretic hormone. Okay, it is characterized by persistent passage of excessive amount of dilute urine and thirst. Now just remember some keywords, that is deficiency of vasopressin, antidiuretic hormone, okay, and persistent passage of excessive amount of dilute urine and thirst. Now types. What are the types of diabetes insipidus? Primary deficiency, secondary deficiency. Now the deficient action of ADH. Now what is primary deficiency? Neurogenic, pituitary, hypothalamic, cranial, central DI. It is due to agenesis or destruction of the neurohypophysis. And the secondary will be, it is due to inhibition of ADH secretion, that is primary polydipsia. Deficient action of ADH, that is nephrogenic DI. Transient diabetic insipidus of pregnancy produced by accelerated metabolism of vasopressin, that is gestogenic diabetes insipidus. Same as it is in gestational diabetes mellitus in pregnancy. Okay, it's common and it reverses by time. Now, causes: central DI, idiopathic, neoplastic or infiltrative lesions of hypothalamus, pituitary or hypothalamic surgeries, severe head injury, rupture cerebral aneurysm, infections, autoimmune familial. Okay, see, now this is the type of central DI. Okay, these are some subdivisions. Now nephrogenic DI: primary congenital or familial, X-linked recessive vasopressin receptor mutations, acquired chronic pyelonephritis, hypokalemia, hypercalcemia, sickle cell disease, protein deprivation, drug induced. Okay, there are different allopathic drugs which been induced with certain amount of drugs, okay, which have been induced by that. Now, which can lead to the chronic renal failure, obstructive uropathy, polycystic diseases. Now, the causes of diabetes insipidus. Clinical features: polyuria and polydipsia. Urinary frequency, that is polyuria, 4 to 18 liters per day. Nocturia, compensatory excessive thirst, polydipsia are most marked symptoms. Other features are change in mentations, insomnia, that is loss of sleep, and weight loss. Skin mucous membrane cools out. If left untreated, changes in LOC, that is loss of consciousness, tachycardia, tachypnea, hypotension. But unlike hypovolemic shock, urine output is increased. Can lead to hypernatremia, restlessness, agitation, diminished deep tendon reflex seizures. Hypernatremia is the term that is increase in the sodium levels. Okay. Now leads to the complications. Now, what are the complications? That is hypernatremia, dehydration, and its neurological sequel. Growth retardation can be there. Then it is hydronephrosis due to excessive urine output. Now, investigations. Careful history is important. Means in any of the disease, careful history is must and important. Okay, yeah. Then comes the examination and the document process presence of polyuria. Okay, polyuria we can just mention only when there is usually 4 to 15 liters, okay, of urine output in 24 hours. Not less than that, we cannot mention that term. And measurement of osmolality of the plasma and urine. It is used to establish the diagnosis. Means certain levels can be used in establishment of the diagnosis of that thing. Yeah. Now urine. See, high 24 hours urine volume. What means, in what cases we can say? If the volume is less than 2 liters, there is no need for further investigations. Means there is no certain use, in the investigations. Clear and low specific gravity of urine. Low urine osmolality are usually less than that of plasma osmolality. Serum sodium is high or high normal, means high to normal, hypernatremia, and indicates loss of water. MRI of pituitary and hypothalamus. Now, short note on water deprivation test. See, this is very important test in order to diagnose diabetes insipidus. Diagnosis or exclusive of the diabetes insipidus to differentiate between diabetes insipidus from the primary polydipsia. Okay. Yeah. Now, what is the procedure for this? Should be done in morning under the observation with 8 hours of fasting. No fluid, that is water deprivation from 7:30 hours for 7:30 hours. Okay. Means you should not have any meal basically for the 8 hours. Measure plasma and urine osmolality, urine volume, and weight hourly up to 8 hours. Abundant fluid deprivation if weight loss is more than 3%. Okay. Yeah. If the plasma osmolality is more than 300 milliosmoles per kg and or urine osmolality is less than 600 milliosmol per kg ADH, that is vasopressin, is given in a dose of 2. Now interpretations. See, we will not go in much details. We will just see this chart. Okay. Water deprivation test. Urine osmolality increases to 500 milliosmol per liter. Okay. Two chances will no much changes. And it increases to the 500 milliosmol per liter, then psychogenic polydipsia can occur. And if no further changes will occur, we will go for diabetes insipidus. Now, administration of desmopressin. Okay. Now, what happens? Increase in urine osmolality, that will lead to the central diabetes insipidus. And if no change in urine osmolality, it will lead to the nephrogenic diabetes insipidus. Primary polydipsia. Patient with the primary polydipsia starts with a low normal plasma osmolality, okay, that is 280 milliosmol per kg. Urine plasma osmolarity ratio rises by more than 2 after the dehydration. Okay. Now, central diabetes insipidus. After the water restriction in a patient with diabetes insipidus, the plasma osmolality rises above the normal without rise in urine osmolality or the specific gravity of urine. Okay. Yeah. Now, urine osmolality remains less than plasma osmolality, and the urine plasma osmolality ratio remains less than 1.5. Okay. After ADH is given, urine osmolality increase 100% in complete CDI and over 50% of the partial CDI patient. Nephrogenic diabetes insipidus, urine osmolality remains less than the plasma osmolality. After ADH, urine osmolality increase by more than less than 50%. Okay. Alternative to the water deprivation test is by infusing hypertonic, that is 5% saline, and measure ADH secretion in response to increasing plasma osmolality.